Hi, welcome everybody. Welcome to our 7 p.m. East webinar. Today we are with Dr. Troy. We are honored to have him with us. And if you allow me, I'll be introducing him to our audience tonight. So about Dr. Freiheit, he's a chiropractic physician of 35 years of service to the chiropractic profession and to the patients that have sought his care. The primary focus of his practice has been directed at the care of individuals involved in motor vehicle collisions. He has been admitted as an expert witness solely based on his experience in the patient subset. His experience includes the intake, examination and treatment, deposition, special investigative unit depositions, arbitration, and trial testimony for the care of over 5,000 MVCs. He has offered successful support of the care documented primarily by the patient file to MedPay reviewers, with winning rebuttals resulting in near full reimbursement. He has researched and written 3 foundational articles for the chiropractic practice, treating the MVC patient with an emphasis on treatment strategies leading to the timely symptomatic recovery of the patient. No therapeutic fault or evidence of spoliation has ever been attributed to his cases. Well, this is an awesome resume. I would love to start hearing everything you have to teach us tonight. Thank you, Dr. Troy, for joining us tonight.
Oh, thank you. And thank you, Maria, for that very kind introduction, and to NAD Pinwheel for inviting me to speak about pinwheel exams and the PI practice. I'm going to share the screen here. And go to this one, share, and view slideshow.
There you go. Awesome.
There we go. Okay. And good afternoon and evening to everyone out there. We had a nice, productive, or fun-filled day. This program, first of all, I'm founder of PI Pro, which is a newer business of mine. And what it does is it researches really all aspects of the personal injury case and care. Also, it provides education and clinic management concepts for individual doctors or group practices that are treating motor vehicle collisions. This program is presented to enhance and support the physician caring for motor vehicle collision patients, improving patient outcomes and reducing therapeutic culpability and minimizing risk to the patient are goals of this presentation. The program highlights include how to use multiple pinwheel examinations and to improve the patient outcomes. Pinwheel examinations interpretations can strengthen the file documentation. We'll talk about that. Pinwheel examination can uncover severe injuries, and we'll talk about that. A strong case benefits the patient, the attorney, and the practitioner. And case value can be strengthened and spoliation of evidence avoided with multiple pinwheel examinations. The picture on the right is a picture of transcripts that I have in my desk here. And for some reason I got a little frog here. All right, so but the testimony offered in these files represents less than 2% of all the cases in the past 8 years. So it doesn't happen very often, but I like to receive copies of my testimony, and you should as well, even if you have to pay for them, but it's good. And you can gain, like I said, if those things could talk, they would tell some very interesting stories, I think, about how the defense sees your case or sees my case, and what strategies they use in the defense of the claim. In every deposition or offering of testimony in arbitration or trial, the results of the pinwheel examination have been discussed. And down in the bottom there, my practice, I average about 30% cervical disc herniations, and actually in 1 year, 37%. And overall, about 65% of the patients have acute disc herniations in the cervical, thoracic, lumbar, or combinations in each case. The persisting positive evidence of the pinwheel examination has successfully supported the claim of an acute herniated disc. So when you're in deposition and or trial and they're talking about pinwheel exams, and it's going on and on, that you're having multiple pinwheel, it seems to cement in the defense's mind that this is an acute disc herniation, and not a pre-existing problem. And if you've worked in the personal injury market, you know how often they try to claim that. Little thing here, okay? So the case value is based on injury severity. More severe injury generates greater case value generally. Depends on the availability or lack of available conflicting evidence. We're going to talk about records to review and how important that is, and specifically the hospital record, the primary care physician, urgent care record, pain management specialist now caring for the patient, and any past imaging records, particularly of the CT or MRI type. Spoliation of evidence, a term an attorney gave me some years back, deals with how the case can be devalued with certain things that happen during the care. For example, patient activities should be managed. And, if you have a case that's in personal injury, you have to maybe manage their workload in the beginning, advise them to limit or discontinue certain exercises or limit or discontinue certain things they do around their house. And those should be in your notes, just that you're instructing the patient to do so and checking up with the patient periodically to make sure they're following that and making any adjustments to those notes. In those depositions, there's times when the patient's symptoms have worsened, and they seem to cue in on those for some reason. For example, you'll have a patient that came in on a Friday, but on Monday they came back and their hands tingling, and they really like to discuss that point. And that could be something that's a problem. The PI Pro program was developed over the last 10 years, and it's really about a strategy of care that I've developed. And if you want some more information about any of that, any of that information, at the end, I'll give you an email. You can contact me. There's not a website up for this yet. It's really one of those ready, fire, aim kind of things that happen. And let's see here, what are we doing here? Yeah, there we go. So there we go. Who increases the value with the discovery of the greater injury? This is a study produced by the Insurance Research Council, auto injuries, claiming behavior, and its impact on insurance costs. And this was originally saw this in a book by Lawrence Nordoff, DC, out of California. And it indicates that the payer increases the value of the case when a more severe injury is present. And this was done in 1994. There's more recent studies of this nature, but the last one I think is $5,000, and you can only get at it if you're an institution. So he had this reprinted in his book, and it's summarized in the next slide, where the items that are plainly printed, laceration, sprain, and fracture, have an escalating value as the study indicates. And in my practice, I kind of interjected where the disc herniations, the traumatic brain injury, and spinal cord injury cases have settled, and how that relates to the original study. And the disc herniations, if they're clean, settle for more than the sprain, but not as much as fracture, and then the brain injury above the fracture. The study that was reprinted in Dr. Nordoff's book, I think, is from 1992, and his book is published in 1994, but the study is not published again in his second edition, which is interesting. But if any of you have been in practice a long time, like guess I'm getting to be, you'll remember that MRI scans were not around to a great deal back in the 90s and 80s. They were just were getting started. And so, as you know, CT scans generally don't prove or show acute disc herniations. And so some of that information just may have not been put into the study at that time. The importance of the pinwheel examination is it's an essential component of your initial examination of the individual that has been involved in a motor vehicle collision. The program will demonstrate how the use of multiple pinwheel exams in the course of treatment of a patient involved in a motor vehicle collision will strengthen and add value to the case. The Pinwheel exam may provide an important bullet point in the development of criteria necessary to support the evaluation management codes used in your practice. If you've ever had a deposition where they ask you to score your examinations relative to the bullet points or points that are required, that's an interesting experience. The Pinwheel exam may provide essential information when defending your case file that an acute disc herniation is present and is the primary cause of the patient's symptoms. And the Pinwheel exam may provide supportive information for your clinical decision to refer the patient from medical specialty care. The picture here is the famous Wartenberg chrome metallic pinwheel that generally, in the literature anyway, neurologist people say they don't use this that much anymore because of the risk of cross-contamination, to include shingles, HIV, hepatitis, maybe the bloodborne pathogens, and maybe even monkeypox. The NAD pinwheel, which is a disposable pinwheel, is what I prefer to test the dermatomes for signs of injury. This picture shows a couple things. One is the potential, what would an infection look like in the arm, in the dermis, and not very pleasant. But I chose this other picture because it shows the old Wartenberg pinwheel and how you would grab the waistline of the testing device and roll it across the skin. And I've had many times where the defense has said, well, how much hand pressure do you put down on that through the handle? And it was never designed for that. You held the waistline. And NAD Pinwheel has developed this device, which you can see in this picture, and how it has a thin spatulated area in the back that you hold with your thumb and index finger. And that works just marvelously, and the wheel glides so easily. The device itself, the NAD Pinwheel, made in the USA, it's single use and latex free and recyclable, is something to dispose of after every use. And all of us have been now through COVID, and we've had patients and people we know that are more sensitive to being infected or to being around viruses and bacteria. And this use of this tool, I think, really puts you in a position of being caring for the patient. And because the NAD pinwheel comes with a plastic wrapper around it, you pull out of the wrapper so the patient knows they're not getting tested with something that was used on the patient before. And after you do the testing, you toss it into the Sharpie bucket, and they know, because there's sort of this feeling that we're not going to infect other people either. So they know the next person is going to get a clean pinwheel. If you're still using the standardized Wartenberg metallic ones, you can get a dozen of those, depending on how busy your practice is, and sanitize or sterilize after every use if you want. But the pinwheel is the NAD pinwheel is so much easier just to throw it away after you've done the testing. Again, this has a spatulated end on it, and what you want to do is engage the pain receptors, the nociceptors, lightly. So just a little bit of downward pressure, and you'll have comfortable, safe, precise, and reproducible pinwheel exam testing. So how does the pinwheel exam work? Well, you know this, and you've done hundreds of these probably. The non-injured patient only feels a light, normal prickling to the pinwheel exam. That's normal, all right? They're feeling something, but it's not particularly painful at all. However, the dermatome is hypersensitized with dorsal root ganglion compromise in the injured patient. The dorsal root ganglion is compromised by direct compression from osseous or disc material, or both. And this can happen with fracture. This can happen with a significant listhesis of the vertebrae. And then, of course, the disc herniation material. Inflammation metabolites from acute disc herniations and ligaments and capsular injuries can also compromise the disc herniation and cause it to become hypersensitized. If you read Croft, and believe me, the defense reads Croft, you should read Croft, get a hold of one of those books and understand what he talks about in there. And he talks about how the inflammatory stage lasts 24 to 72 hours. And that's true for some things, but the Quebec Task Force states that the inflammatory stage can last 3 weeks in the whiplash-associated disorder cases. And that's important to keep that in mind, that inflammation can continue. In this slide, we're showing how anoxious stimulation, whether it's the pinwheel or pin prick, how that activates the nociceptors, and that message is communicated to the dorsal root ganglion, through the dorsal root ganglion to the dorsal horn, crossing to the spinal thalamic tract, and then projecting afferently through to the thalamus and then to the sensory cortex for localization of the sensation. In a herniated disc, particularly one with extrusion, you may have direct physical compression of the dorsal root ganglion. And there also is very likely to be inflammatory chemicals in the area too that are sensitizing the dorsal root ganglion. In a central protrusion disc herniation, you may not have compression of the dorsal root ganglion, but you're going to have these inflammatory metabolites in the area that are sensitizing the dorsal root ganglion and causing that dermatome to be hypersensitive. Interesting with central protrusion disc herniation patients, they may even have paresthesia type symptoms for just a few days, but not lasting. And so you kind of falsely get the idea that, well, they don't have a disc herniation, but maybe they do. The pinwheel exam protocol and procedure. So I like to test each area 2 times before comparing to the other limb to ensure the patient correctly senses the stimulation. I prefer to utilize the NAD pinwheel by rotating it around the limb, comparing significantly different dermatomes, as some overlap does occur according to Croft. He talks about how that may be a challenge, maybe sometimes if you're rolling the pinwheel up and down the limb. For the extremities, compare one side to the other. So you'd use the brachium against the brachium, the antibrachium against the antibrachium, and the hand against the hand, and get their understanding of any sensory changes. And for the thigh, roll the pinwheel obliquely from the outer thigh to the medial knee. And then for the lower leg, around the leg and across the foot to finish the limbs off. And in the spine, compare the left and right of each region. So do the cervical, left and right, thoracic, left and right, lumbar, left and right, and get the patient's input from what they're feeling. In this picture, we're showing the NAD pinwheel in action, and we're doing it where we're rolling it across the arm, with some light downward pressure. This is a slide of the upper extremities. And these are common dermatomal arrangements that you probably are aware of. And again, you may have charts in your office that show this to be slightly different. The lower extremity dermatomes and the spinal dermatomes. And when I do the spine, I do it on the back only, and that seems to work out pretty good. Some terms you want to place in your chart to make it easy for everybody to understand what it is you're getting from the test. If there's no apparent findings, NAF, you write that in when you do the test for each of the areas. I worked in a big group practice, I think the largest personal injury practice in the United States here in Phoenix, Arizona, for a number of years. And one of the things that they would hone in on if you're writing positive or negative for this test, and that brought up a lot of discussion versus the NAF finding if there's nothing there. Of course, in your notes when you're taking your history, if the patient says they have tingling in their arm or leg or middle of their back, that's a paresthesia. The hypoesthesia is when there's abnormally decreased sensitivity to the stimulation. So they feel numb in a spot on the arm or the back. And that can be a sign of a spinal cord injury, just to be aware. Hyperesthesia is when there's abnormal sensitivity increase to stimulation. And hyperalgesia is when there's excessive sensitivity to low-level pain, as would occur with the pinwheel examination. So the pinwheel examination does produce a mild amount of pain, but they shouldn't have severe pain with that. Hyperalgesia is something you don't see a lot. I've probably seen 3 in the last 1,000 cases or so. But its implication of a spinal cord injury or severe disc herniations and central sensitization with windup of repeated depolarization of type C and A delta pain fibers, more the type C type pain fibers. In the scenario of the 3 I've seen, 1 was in the low back and 2 were in the neck. And the patient will demonstrate a brisk reflexic limb withdrawal and probably tell you they never want you to do that ever again to them. And so when I'm doing the pinwheel exams, I stand to the side, especially with the lower extremities, because that leg will come out so fast that you could get kicked, and you don't want that. And in the arm, another reason I do 2 passes on each area of the body is in the one case, it was really interesting. She thought she felt something, but on the second pass, and this is this windup issue, she really felt it and jerked away. And all those cases had pretty significant herniated discs with extrusions that had to be co-managed. Croft's mechanism of delay instability. In his book, there's a section of his book that's really great. And if you can read a lot of Croft, that really helps you in your practice, because the defense does, I'm pretty sure. He talks about when there's a reduction in muscle spasm and splinting in the initial few weeks post-injury, that dynamic x-rays and follow-up x-rays allow for better imaging of vertebral instability. Posterior longitudinal ligament sprain or subfailure results in an anterior subluxation seen on the flexion view, and likely central protrusion disc herniation is the involved and could be imaged on the MRI. A pinwheel examination at 3 weeks may now demonstrate again hyperesthesia, suggesting disc herniation. So this is at 3 weeks. I've had it go even into the 5th and 6th week. So keep doing those exams, and we'll talk about the strategy for that towards the end here. Essential disc herniation, again, is implicated with spinal cord injury due to the direct posterior disc protrusion. And these are significant injuries and may require orthopedic or neurological referral or co-management. The first one of these I ever saw was about 25 years ago in a patient I was treating. In about 4 weeks, the patient was still having neck pain that would get better with care, and just go back and forth, back and forth. And the attorney actually suggested that we get a second opinion from an orthopedic surgeon who ordered an MRI, which they weren't very common back then. And sure enough, it came back with essential disc herniation. No extremity symptoms, no problems like that, no weakness, nothing like that. So they can be really kind of hard to detect. In fact, pinwheel findings may be the only sign of essential disc herniation, because the central protrusion disc herniation may fail to compress the dorsal root ganglion. Central protrusion disc herniations, in my opinion, are the most common disc herniation I've discovered in motor vehicle collision. And this is based on hundreds and hundreds of MRIs that I've ordered. They always come back with sort of a central or just off to the side, but not a lateralizing disc herniation. Because there's no physical dorsal root ganglion compromise, there's likely no ongoing radicular symptom. And we talked about that student just earlier in the last slide. Inflammatory metabolites associated with the acute central protrusion disc herniation injury may continue to sensitize the dorsal root ganglion for weeks beyond the normal cessation of the expected inflammatory process of myofascial and ligamentous soft tissue healing. Windup due to the acute central sensitization can be identified by the patient's response of hyperesthesia or even hyperalgesia to repeated pinwheel examinations several weeks post-injury. Value-added diagnoses to include in your file: traumatic cervical, thoracic, and lumbar herniations, and the current code that I use is there, S13.0XXA. Significant cervical instability, if you find that in your examinations, S13.4XXA, and traumatic cervical spinal cord, S14.109. One of those I have found in the last 1,000 cases, but had symptoms in the pinwheel examination. A test that I do in my practice on every single motor vehicle collision patient at the end of the visit is a modified cervical distraction test. This cervical distraction test can be performed daily as part of your aftercare procedure. So remember, with your manipulations, you have to have a pre-manipulation, the manipulation, and the post-manipulation. And that's what I do for that. The test can be modified to do from behind with both hands cupping the occiput instead of grabbing around the chin in the back of the head and applying some gentle upward pressure. 3 to 4 weeks post-injury, sharp pain in the cervical spine is indicative of a likely disc herniation, and if at the suboccipital region, an alar ligament sprain or subfailure. Hyperesthesia may still be present, identified by the pinwheel examination, and thereby supporting it to be an acute disc herniation. Dr. Nordoff, who I mentioned earlier, in his second edition, talks a lot about medical records review and how it strengthens the case. And his suggestion is to review hospital records of the most recent motor vehicle collision. My practice is in the Metro Phoenix area, and we have a lot of hospitals, but it seems like patients seem to go to the same hospital when they get into trouble. And so you'll probably be able to find records that that hospital may have going back even 5 years for the patient, and certainly any indication if there was a past motor vehicle collision. The primary care physician or urgent care records, if seen for the present motor vehicle collision. Primary care physician records if seen for a past motor vehicle collision in the past 5 years. Specialist care records if the patient has been seen by referral by the primary care physician. So sometimes you'll get records from the primary care doctor that the patient is being seen by pain management, and you get those records, and on the patient's initial history, they said, well, my low back pain's an 8, but on the specialist care records, they're saying their low back pain's an 8 too. So sometimes you have to get an understanding from the patient as to what's really meant by that. Past imaging records of MRI and CT variety. One of the things Croft talks quite a bit is when you have an injury and then you have another injury, those soft tissues are not as strong as they were from before the first accident. So you can get multiple disc herniations occurring over a period of time with successive accidents. So how far back do you go? 5 years if available with the hospitals. And sometimes when you petition the hospital for records, they don't have any records other than the one of the current accident. The date of the injury from primary care and urgent care. 5 years for post primary care physician or urgent care seen for a past motor vehicle collision. Past 6 months for pain management specialties currently seeing the patient, and imaging extending back 5 years for MRI and CT. Clearing the past medical records may prevent the defense claims of a pre-existing injury, and it never hurts to have those records in your file. Documentation is the key to the motor vehicle collision settlement. Does the patient record support the patient's complaints and injuries? Do your records support the level of CPT code billed or therapies and treatments provided? Have you reviewed the recent past medical records? And the defense likely has. So that's just how that is going to work in motor vehicle collision cases. Summarized in Dr. North's book, this concept that the failure to review medical records that could demonstrate the patient's injuries are pre-existing could undermine the case and may reduce the probable settlement and therefore your fee recovery. So when you get all these records, I don't know how you have been charging for it because you should get paid for what you do. I've always used and have for years the 99212-25 code, and I know many are aware that the requirements for these E&M codings was changed by a 2021 guideline by the AMA. The new code, or the new way you see this, is that the history and physical exam are not elements in the selection of the E&M code, but must be sufficiently documented to be deemed medically appropriate for the patient at the visit in the opinion of the provider. And I think that's a key statement there, that you decide what's medically appropriate in the case. The E&M code selected is based on total time or the level of medical decision-making. And this is an important benefit to us providers when we're reviewing these records, and we should take the time to share some of that information with the patient. So the total time spent face-to-face and non-face-to-face for the 99212 code is 10 to 18 minutes. So you get a big packet from the hospital. Well, maybe it takes you 4 or 5 minutes to look through that, and then you're going to discuss that with the patient. It's relatively easy, I guess, is what I'm saying, to get to the 10-minute mark when it comes to records that you need to review, and should review some of that with the patient. You probably have seen hospital records where a test was recommended that the patient follow up with because of some finding at the hospital exam, the emergency room exam. And just to remind them that they need to do that. They may have forgot about that. It might be important to their health. And you want to document qualifying total time activities. The other way to do this, which is far more cumbersome perhaps, is the medical decision making, which is based on the 3 elements. 2 out of 3 are required, where you list in the visit and your documentation and your notes the number and complexity of the problem, the amount or complexity of data to be reviewed or analyzed, and the risk of complication, morbidity, and or mortality of patient management. In my opinion, the time-based is a much simpler way to qualify this code. Qualifying total time activities to meet this time requirement can include preparing to see the patient to review tests. So that's where you're reading the documents before you go into the actual visit. Counseling and educating the patient, family, or caregiver. Documenting clinical information in the EMR, if you have one of those. And performing a medically appropriate examination, for example, a pinwheel exam or a cervical distraction test, on the same day you review the records. These things can all, and any of them can be combined to meet the time requirement, but the key is documentation. In the chart, you need to document what you did and how long you took to do it. Below are some charting phraseology examples that you can include in your notes, and you can get creative with these depending on what you're reviewing. For example, you've spent 8 minutes performing a pre-visit review of the hospital records, and then you spent 4 or 5 minutes going over the information with the patient, and you can state that however you'd like. But the key again is to chart in your document what you did and how long to do it. The pinwheel examination strategy I use in my practice, and I hope you will adopt this, because it's good for patient care and it increases your case value when you find these value injuries, is number 1 on the initial exam. Number 2, at the 2-week follow-up exam, if you do an exam then, at the 1-month follow-up exam, each time you review records obtained relative to the case and are reviewing with the patient. So in cases in the past, I have had 2 or 3 of these 99212 codes in the bill because of records coming in that I've reviewed with the patient. And in those those deposition documents, none of this has ever been questioned. And each follow-up exam, where on a previous examination there was a notation of a positive pinwheel finding, you should continue to do the exams and continue to do this on each exam until the finding is no longer present, or until the patient is either referred to another provider and or is no longer under your care. And it's almost dinner time. Pinwheel exams are essential to the practice of the practitioner treating motor vehicle collision patients and should be performed at least 3 times in the first 30 days. You're going to pick up a lot of injury that way. The discovery of spinal disc herniation, spinal cord injury, and impending delayed instability can significantly improve the case value. You should retrieve and review pertinent medical records with the patient on their next visit, properly code the visit. Many probably already do this, but I know some people don't, but you really should, because it's your education, training, experience are necessary to understand the documents and relate this information to the patient. They couldn't look at these documents and understand what they mean. They require you to, tell them what's meant by the reports. I hope you'll join with me and other providers to practice safely your pinwheel exams and avoid any cross infection while performing your pinwheel exams by utilizing the NAD Pinwheel products. The case value will likely increase. And if you have any questions about this program or any of the information that PI Pro does, I invite you to contact me at troy@pipro.net. And NAD Pinwheel has this opportunity for you. I think you can do this at any time to purchase these wonderful devices at a very reasonable rate.